We all know that colonoscopy is the gold standard for colorectal cancer screening, but with only 60% of the people in the country who are eligible being screened, we need more options for patients who are unable or unwilling to have a colonoscopy. Now, the FDA recently approved a blood test called Shield, which is made for colorectal cancer screening. And there's also a newer generation of the Cologuard stool test that's been used for about 10 years now. That was just updated recently. And I'd like to go over the pros and cons of these non-invasive tests today. So keep listening if you want to find out if avoiding a colonoscopy is in your best interests if you do one of these other tests. Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist practicing in New York. Today we're going to talk all about colon cancer screening using non-invasive testing. So recently, a blood test was FDA-approved for colon cancer screening. And there's also several stool tests that are available for colon cancer screening. These tests are meant to be used instead of colonoscopy. So I'd like to explore the pluses and minuses, or the pros and cons of these kind of tests in relation to colonoscopy for colon cancer screening. So colon cancer, unfortunately, is a very common cancer. So in 2024, I'm recording this episode in August of 2024, colon cancer is expected to claim about 53,000 lives in the USA this year. So it's a very common cause of cancer death. And the statistics are that about 150,000 new cases of colon cancer are going to be diagnosed this year. That's in men and women together. That's colorectal cancer, so cancer in the colon, cancer in the rectum. More than 150,000 cases expected in 2024. Now, the tragedy here is that many of these cases are preventable, and they're prevented by screening. So screening for colon cancer, or screening for any cancer, or any disease, is thought of as taking people who are asymptomatic, meaning they have no symptoms. In the case of colon cancer, there's no blood in the stool, there's no belly pain, there's no change in the weight, there's no change in the bowel habits. They're just regular people walking in off the street feeling totally fine. You take them of a certain age, and for colon cancer, that's 45 years of age, and you subject them to some type of test. And the test will tell you if you're either likely to have colon cancer or if you have colon cancer. And these are called screening tests. And why do we pick 45 years of age? Why don't we pick 43 years of age or 47 years of age or 62 years of age? The age used to be 50 years of age that the average person would come in and get a colon cancer screening test. But then they dropped it to 45. So this happened a couple of years ago after we figured out that younger people are getting colon cancer. So the average age of onset of colon cancer is about 66 years of age. That's in terms of when people get diagnosed. So it takes about 10 to 15 years for colon cancer to start. And it starts as a little growth called a polyp in the colon. And a polyp will grow, and eventually turn into cancer. Not every polyp turns into cancer, but every cancer started off as a polyp. So if the average person gets diagnosed in their mid-60s, they figured that if we started looking at the age of 50, we'd save a lot of lives. And that's true. But then new data came out that showed that a lot of people are now getting diagnosed in their early 50s. That trend is actually accelerating, meaning that from the 1990s until now, more people are getting diagnosed with colon cancer at younger ages. That's kind of alarming, and that made them drop the age to 45, with the hopes of picking up people who would not be picked up earlier if they started at 50. So this will hopefully pick up people at 45, 46, 47 that would have gotten colon cancer when they were 50, 51, 52, 53. And anecdotally, from someone who performs colonoscopies, I'm seeing a lot of polyps in that 45-year-old and above age category. So would those polyps have turned into cancer earlier? Nobody really knows, but we see big polyps in people who are young, and we take them out, and we don't let them get colon cancer because I don't want to find out if they're going to turn into colon cancer. So screening is taking people with no symptoms and checking them for a disease that's common and deadly, with the hopes of preventing the disease before it happens, or preventing death from the disease before it happens. And in terms of colon and rectal cancer, there are several different screening tests to choose from. But before I talk about that, I want to talk about a case. And this was a recent case. So I'm going to change some of the details to protect the patient privacy. But I was called to see a patient in the hospital a few months ago who came in because he passed out. He's 73 years old. He was home and he felt lightheaded and he woke up on the floor, basically lost consciousness. His family brought him into the hospital and he was found to have a hemoglobin, or a red blood cell count, of about 6.5. That's pretty low. If you know what hemoglobin's all about, normal hemoglobin for a man is somewhere around 13 to 15 or even higher, depending on your age. So he's walking around with less than half of his blood in his system. After he was given blood by the hospital, he felt fine. No abdominal pain, no change in the bowels were reported. He denies any history of colon cancer or any type of cancer in the family. He's not had a colonoscopy or any other diagnostic testing or screening testing in the past. And in the hospital, they did, besides basic lab work and stuff, they did a CAT scan of his body for whatever reason. But the CAT scan showed a possible mass or growth or a tumor in the transverse colon. So I was called to see the patient, saw him, and signed him up for a colonoscopy. And we did the colonoscopy in the hospital, and it showed a large ulcerated fungating cancer in the transverse colon. And what that looks like on a colonoscopy is just a big growth of abnormal tissue that's kind of oozing blood. We take biopsies of it, and the biopsies come back and show colon cancer. So it was not really a big surprise because we had the CAT scan showing the cancer already, and the story made sense. And as someone who is of a certain age with anemia, colon cancer is very high up on the list of things that will cause that, and that's what we found. So he went on to have surgery, and he did well, and he's okay. But why did it have to get to that point is the question here. Screening should have prevented that. He should have had some screening testing done at the age of 45 or 50 or 55 or 60 or any age, really, before it came to him being in the hospital with a cancer. So there were many, many years to prevent this cancer, but it didn't happen. And I don't ask people why they don't get screened because it seems like it's a moot point at that time. You know, at that point, it's kind of, I don't want to add like insult to injury, but why don't people get screened? And it's a valid question. And anyone listening to this right now knows the answer why people don't get screened is because colonoscopy is not so much fun for people. Sometimes the thought of colonoscopy is worse than the actual experience. But it's very hard to convince someone that a colonoscopy is not often a terrible test. It's pretty easy when they've never had it before. And what they think about is having this giant tube shoved up their butt. So nobody likes that. Even though we're not doing any shoving, people think that that's what's happening. It's more of a finesse thing. It's a gentle procedure in good hands, and you're asleep for it. But not everybody knows that, and they just have this idea that colonoscopy is like a brutal test from medieval times. Now, that's the reason why a lot of people don't get screened, and they also know about the preparation you have to do, the drink or the pills or whatever it is that you have to do to get cleaned out, and they don't want any part of it. So they take a gamble with their health, and a lot of them end up like our friend in the hospital with a big colon mass. And a lot of people end up just fine. But the issue still remains that we need some good non-invasive testing for colon cancer, or non-invasive screening testing for colon cancer. And currently, we do have a few of those things, but none of them are great. The current guidelines say that you can do stool testing for colon cancer prevention. And back in the day, this was stool guaiac testing, which are those little cards that you would take home with you and put a little stool on and send back to the doctor's office. But they're terrible. They're very poorly sensitive. They miss cancer all the time. They show stuff that's not cancer all the time. They're kind of more of a academic interest in terms of the archives of gastroenterology and should not be used anymore in the real world. Then there's FIT testing, which is much more accurate. It's also a stool-based test. You do it at home, much more sensitive, finds cancer much more commonly, much more specific, meaning when it's positive, it's often due to cancer and not some other thing like a hemorrhoid. But also has to be repeated every year. You have to handle your stool. It misses lots of stuff. It misses cancer. It misses polyps. It's really not ideal. It's a good way to find out if you have cancer, but it's really not a good way to prevent cancer. Then there's the more advanced stool test called the Cologuard test. You do this every 3 years. It was approved by the FDA in 2014, I want to say, or at least, about 10 years ago. And it's a combination of a FIT test, or a fecal immunochemical test, which is the test for blood that we just talked about, but it also combines testing for abnormal DNA that's found in cancer and sometimes found in large polyps. So it's a combination of these two things, and you get a positive result or a negative result. It doesn't tell you what caused the issue, but it does tell you if you need further attention with a colonoscopy. So you do a Cologuard, it comes to your house, it's a package that gets mailed to your house, you basically poop in the box, you send it back to them, and you get a result in a week or so. Now, the number of people that do Cologuard testing, I think, is increasing across the country, but it's not really a ideal test for everybody. It's really good if you're not going to get colon cancer screening any other way, because I'd much rather that you get a Cologuard test than just like take your chances and do nothing. But the big problems with the Cologuard test includes false positive tests, meaning lots of people get Cologuard tests, lots of them come back positive. We end up doing colonoscopy and we find nothing. So it's one of the downsides of Cologuard testing. But all of these non-invasive tests imply that if you have a positive result, either on the stool test or a Cologuard test, that you go for a high-quality colonoscopy. And that's ultimately what detects the cancer or detects the polyp and allows for treatment to happen, either surgery for the cancer or removing the polyp during the colonoscopy. So none of these tests really prevent you from getting colon cancer. Ultimately, colonoscopy is the only one that does that. But all these tests are ways to determine if you really, really, really need a colonoscopy if you didn't want to have one in the first place. Now, colonoscopy is still considered the gold standard screening test. It's still considered the preferred and the best test for colon cancer screening, but we recognize that not everybody wants to get a colonoscopy. So to talk about Cologuard testing and if it's a good fit for somebody or not, we really have to understand the statistics behind it. And at the risk of making this super duper boring, I'd like to go through some statistics very quickly. And really just two concepts. One is sensitivity and one is specificity. So unfortunately, no test in the world is perfect, and no test is perfectly sensitive and perfectly specific. But let's see what things would look like if we had a perfect test. Now, sensitivity refers to the ability of a test to find a true positive. So if you have a group of individuals with a known disease, how many of the people who test positive have the disease? That is going to be the sensitivity. So a very sensitive test has a very low false negative rate. If you have a very specific test, that refers to the ability of a test to identify individuals without a disease as negatives. So if you have a very specific test, you have a very low false positive rate. So if you think about this, it's very hard to keep these definitions straight in your head. It's hard to remember what these things are. So if we want to look at these concepts in terms of a visualization, picture you're living in a small farming town somewhere in the Midwest of America, and there's 1,000 people in your town, no more, no less. But it turns out that 4 of those people are actually evil space aliens that came from some other planet, and they look exactly like humans, but their intention is to destroy the Earth. And they're kind of living in the community studying us right now. So we want to develop some type of a detector to figure out who these space aliens are, because you can't tell by looking, you can't tell by doing blood tests. So we develop a special scanner device that we can use. We make everyone in the population walk through it. How would that scanner function if it was perfectly sensitive? If it was a perfectly sensitive machine, it would pick up every alien that came through it. So if 1,000 people marched through, all 4 aliens would be detected on the scanner. If the sensor was perfectly specific, it would also mark all of the normal people, the 996 normal people out of the 1,000 who came through, as normal. So you can trust either if it gave an alien or a non-alien result. If it was positive or negative, you can trust that because it was perfectly sensitive, perfectly specific. Now in reality, no test is perfectly sensitive and perfectly specific. And the more sensitive you make a test, the more likely you are to pick up things that are not true positives. So in the case of, or bringing this back to colon cancer screening and not space aliens, which is kind of silly, the more sensitive you make a colorectal cancer screening test, like a non-invasive one, like a Cologuard test, the more false positives you're going to pick up because you're so fixated on not missing a true positive, because it's a tragedy to miss someone who really has cancer and tell them they're negative, that you accept the fact that we're going to pick up some other type of noise, and that noise comes in the form of false positives. And that's the biggest problem with Cologuard testing. So they made a test that's pretty sensitive, but it's not very specific. So if you take people who do Cologuard testing, and this is basically the study that was done on Cologuard testing that got it FDA approved, they took 10,000 people and they did colonoscopy on all these people. So they knew if they had colon cancer or polyps or nothing. And they also subjected these 10,000 people to Cologuard testing. And the colonoscopy and the Cologuard test results were not known to each other, so it was a double-blinded type study. And they basically looked and saw the performance characteristics of the Cologuard test. Now, it turns out that the sensitivity of the test, meaning how many times it picked up colon cancer when cancer was indeed present, was 92%. So that's pretty good. Means that it barely misses cancer. Well, it missed 8% of the cancers that were present, but much better than missing all of the cancers that were present by doing no testing, right? However, it was far less sensitive for picking up large polyps, so advanced precancerous polyps, meaning not little nothing polyps, but big polyps or polyps that have certain characteristics that are most likely going to turn into cancer at some point in the near future. It only picked up 42% of those, so it missed most of the polyps, most of the serious polyps, and almost all the small polyps. So the deal with Cologuard is that it's really good at picking up people who have cancer, and not much else than that. It's not going to necessarily prevent cancer. It's not going to necessarily tell you if you have a polyp, but it's going to tell you if you have cancer at the time. And it will miss cancer about 8% of the time, but that's a gamble that you're willing to take if you're doing a Cologuard test. Now, the other way to look at it is the false positive rate. So the false positive rate of a Cologuard test is actually quite high. If we look at all the people with a positive Cologuard test, about 4% will have colon cancer. About 51% will have a precancerous polyp. And the remaining people, about 45%, will have nothing. There'll be nothing found in the colonoscopy. So 45% of the people who get a Cologuard test that turns positive have nothing found on their colonoscopy, which means that of those people getting a Cologuard, lots of people are getting subjected to colonoscopies that don't need to be done. So that's the big weakness of a Cologuard test in terms of a false positive. It's an inconvenience. Patients get annoyed, they get anxious, and a lot of these colonoscopies end up hitting their deductible because they're not screening exams anymore, they're diagnostic exams, because the screening exam was the Cologuard test. So the insurance treats it the same as finding blood in the stool for some plans, which is annoying because the patient gets a bill as opposed to being covered by their screening benefits. But that being said, I found lots of people who have positive Cologuard tests, and they're happy they did it because when we go do the colonoscopy, we find a big polyp that we remove, or a big precancerous polyp that's close to becoming cancer, or a small cancer that was detected and it was a life saved, rather than not detecting the cancer early and having cancer at a late stage a few years down the road. But the con of the Cologuard test is that it doesn't really prevent cancer very well because you don't pick up lots of the polyps that cause cancer. So you have to do it much more frequently. You have to do it every 3 years. And even that, there's no guarantee it's going to pick up everything. So you're always allowing yourself to miss some cancers for the sake of convenience and less invasiveness. And that's okay if people understand that that's the trade-off they're making. When it's offered as a equivalent test to colonoscopy, that's really not true. It's really not equivalent to colonoscopy. It doesn't protect you anywhere near as well. It does not prevent cancer from happening anywhere near as well as colonoscopy does. If you figure that colonoscopy rarely misses large polyps and occasionally misses small polyps, and Cologuard almost always misses small polyps and rarely picks up big polyps, they're different tests. So one is colonoscopy, which is really being proactive and trying to prevent your risk of getting cancer down the road or reduce your risk of getting cancer down the road, where Cologuard is answering the question, do I have cancer right now? Yes or no? And if I don't, then I'm fine with that. So we choose these tests for different people. And I'll get into that at the end of at the conclusion of this episode, kind of how I use it in clinical practice. That's the Cologuard test. That's the first generation Cologuard test, the one that's been out for about 10 years. So they just recently had an update or a study that basically studied a new Cologuard test. It's the same authors, and it's just like a better test. They just tweaked the DNA sequences they're looking for to reduce some, really for the goal of reducing some of these false positives. And this study will be linked below in the show notes if you want to dork out and read the whole thing. But basically what they found was they improved the sensitivity by a little bit. So they got the sensitivity up to about 93.9%. So a little better than 92, but basically the same thing. And they got the false positives down to about 30%. So that's improvement, down from 45% down to 30%. So it's a little tiny bit more sensitive and a lot more specific, even though the specificity is not great. So lots of false positives still, but better than before. So second generation is better than first generation. In terms of this study, is this product out for general use at this point? I'm not sure. I've been ordering Cologuard tests occasionally, and it's the same test I think they get, so I'm not sure if this one's really made it out there yet. But this study that was published in March did show improved findings. So hopefully this will be coming out soon. Now, even with the second generation test, they're still missing 6% of cancers. Just so you know, it's not a perfect test. The miss rate on colonoscopy of cancer is less than 1% in good hands. So the miss rate of colon cancer on the second generation Cologuard test is about 6%. So in their study, they found 98 cancers with the colonoscopy, and they found only 92 of those people with the Cologuard. So much better than nothing, but there's a few people that are going to slip through the cracks if they do Cologuard testing. But the most exciting thing probably is this new test that just got FDA approved. It was also published in March of 2024, but the difference, and I'll link this study below from the New England Journal of Medicine, but the difference is that this is a blood test. So you collect some blood from a vein, just like you would check your cholesterol or whatever else, and it's a blood test for colon cancer. And we've had blood tests for colon cancer in the past, but they have not been FDA approved. And this one just got FDA approved earlier this month. So that's a big deal. Now, this test is called SHIELD. I guess it shields you from colon cancer, although nothing really shields you from colon cancer besides a colonoscopy, guys. Come on. But it's called SHIELD. It's a cool name. And how does it work? Well, they send off some blood, and they look at DNA as well in the blood. So there's different DNA sequences that you can see in the blood in someone who has colon cancer. So in this study, they talked about the test in great detail, and they studied it in a pretty good population of people. So if you want to do a test on screening, you want to do it on a screening population, and you want to do it in a diverse population, men and women, different ethnicities, and they did a good job. It seems like here the participants were collected between 2019 and 2022. There were 22,000 people enrolled. They found that 7,800 met all the screening and inclusion criteria and had the test successfully done. So that was the number of people that they studied this in. So the Cologuard test was like 10,000, but this was pretty good too. It was almost 8,000. And it was a really good mix of ages from 45 to 84. It was about half women. It was a mixed group in terms of race, pretty much mirroring the population of the United States. So it's pretty applicable. You can't just say like it's only one small group of people in another country that's very homogenized. So this is a really good study population for looking at a screening test. They basically did the blood test and they did colonoscopy, and they tried to determine the characteristics of this blood test. The interesting thing I should mention, and I don't know if this is just for the study or if this is the way the test is done, but it says that they collected 30 to 80 milliliters of blood for this test. Now, they may have collected extra blood because they needed extra blood for research purposes, but that seems to be a ridiculously high amount of blood to collect from someone for a single test. So if that's the way the test comes out to the market, it's going to be kind of scary because 80 milliliters of blood is like no joke. But if it's hopefully just for example, a regular blood test is a few milliliters. It's like 5 or 10 milliliters, those little tubes. So, think of giving a bottle of blood for this test, and it's going to be a little scary. But I don't think that's going to be, ultimately, I have a feeling it's going to be less blood than that you'll need for this test. But that's just a little interesting side note. But what do they find? They took all these people, and they found that in the people who had colon cancer, proven by colonoscopy, that they detected 83% of them with this blood test, meaning that they missed 16.9% of people who had colon cancer. So they found about 83% of the people, they identified them correctly, and they missed about 16.9% of the people with colon cancer. So that's not really great. It's pretty cool. I mean, it's better than nothing, but it's not ideal. I mean, you're missing a lot of cancers here. If you're sending the entire population for this test and you're missing 17% roughly of the people with colon cancer, that's a big group of people. It's not great. Now, it's much better than nothing. It's much better than just sticking your head in the sand and doing no testing. But it's not perfect or even close. And I have to hand it to them. This is like probably first generation. So maybe in 5-10 years or so, there'll be like a much better blood test that will pick up much more people and miss a lot less people. But for the time being, the SHIELD test is pretty good if you don't want to get a colonoscopy, but it's not great. Cologuard picks up a lot more people who have cancer than this one does, although you have to handle stool, so that's the downside of that. So just sending off your blood, you're going to miss cancer in a lot of people. And what else? It had a false positive rate of about 10.4%. So those are people who end up going off to have unnecessary colonoscopies. But that's pretty good, actually. False positive of 10% versus the false positive of the new Cologuard test of 30%. That's pretty good. So I think it's really, the big problem here is the sensitivity. It's not picking up enough people who have colon cancer. and detecting them. And they're going about their day and thinking they have nothing wrong with them because their blood test came back negative, but in fact they have colon cancer. And this is not different than many other tests that we use. I mean, we check PSA tests and other things that miss stuff all the time. We check tumor markers all the time that miss things all the time. So these blood tests are by no means very sensitive, but it just has to be taken into account as a limitation of the test. And I think that when this trickles down to primary care and whatnot, that people are just going to offer it like, hey, if you don't want to get colonoscopy, do this blood test. And I get it, because there's only so much time for people to talk about colon cancer screening when you have a million other things to do with a patient. But I don't think it's fair to say this is equivalent to a colonoscopy, because it's not in any way. But if it gets those extra 40% of people who are not currently getting screened, or 30 to 40% of the population is not getting screened for cancer, for colon cancer, if it gets them screened, that's going to pick up a ton of cancers that otherwise would have not been identified. So it's very good in terms of getting those people in who are not getting colonoscopies. And that's the same for the Cologuard. It should not be an alternative to colonoscopy, but it's really good for getting people who have not had any type of screening in for appropriate testing. And if we miss a few of those, it's almost acceptable, because you would have missed all of them, because those people were not going for colonoscopies anyway. So if it catches 83% of the cancers, or if it catches 94% of the cancers like the Cologuard does, that's much better than missing all of them. So you have to look at it in that light, not as an equal alternative to colonoscopy, but as a secondary alternative. And the authors of this study point this out, saying that it's not the most sensitive test in the world, but it's pretty decent. You should probably do it every 3 years. That's what they recommend doing. So check a Shield test every 3 years. And they're saying that the same thing that I'm saying basically, is that with about 50 million people in the country who are not screened, it's helpful to get those people screened with a blood test. There's really no barrier. People get their blood work done regularly for all kinds of stuff. And if you throw on this test, you'll pick up a ton of people who would have been surprise diagnoses of colon cancer as they got older, like our man in the hospital who passed out. Could have been a lot worse. He could have passed out, hit his head. He could have not been detected at all until the cancer metastasized, but he kind of fell through the cracks but got picked up at the last second. But if you do one of these tests, a Cologuard or a Shield test, if he did one of those tests beforehand and was one of those people who got picked up, he would have been better off, because that would have led to a colonoscopy. He would have found the thing earlier, and he would have had hopefully a better outcome, because the problem would have been handled earlier before he developed advanced cancer or whatever else was going to happen. So in summary, I think that with about 53,000 people dying this year from colorectal cancer, any screening modalities that we can offer are better than none. And this blood test, the Shield test, is really exciting, but it's not better than a colonoscopy, and it's not equivalent to a colonoscopy. There's a high miss rate on the blood test. The Cologuard test is a very high false positive rate. And at the end of the day, you have to look at what you're doing here. So by doing these non-invasive tests, you are sacrificing quality for convenience. And that's okay if that's a sacrifice you're willing to make. But if you want the most conclusive test and the most protective test, colonoscopy is still the gold standard. And I don't think there'll be a better gold standard at any time, because it's the only test that allows for direct visualization, and the only test that allows for removal of these precancerous polyps that, if you leave in place, can turn into colon cancer. And I'm sure as time goes on, we'll get a much better array of non-invasive tests that are available to us. And once the sensitivities and specificities are both above 90%, then we'll have an amazing repertoire of non-invasive screening tests available to us. But currently, colonoscopy is still the king. Now, at the end of the day, any test that you're willing to do is better than the perfect test that you're not willing to do. So if you're not willing to get a colonoscopy for various different reasons, then please do one of these non-invasive tests. They're much better than just ignoring the problem, which claims so many lives every year. And in terms of how I think about these tests as a physician who works in this field, I look at the patient's entire situation. So if someone is young and healthy and doesn't want to get colon cancer and they're 45 or above, in my mind, colonoscopy is the only good choice, because you're preventing cancer for 10 years. You're intervening in the natural history of the disease early on, removing polyps, and you're doing a true prevention type test. You're being proactive, and you're trying to save someone from getting cancer who has a ton of life still left in them statistically. So to find a 45 or a 50-year-old or a 55-year-old with a big polyp and remove it you're potentially giving that person a good 40 to 50 years without colon cancer. Where if you do a colonoscopy on a 79-year-old and find a big polyp and prevent colon cancer, it's still a good thing to do, obviously, but that person does not statistically have 40 to 50 years left in them. So at a certain point, depending on the patient's preferences, their age, their health problems, their family history, their symptoms, etc., you are looking more to just detect cancer if it's present. So as people get older and as they're approaching 80 to 85, especially if they've had a high quality screening like a colonoscopy in the past, then I'm more prone to send people for these non-invasive tests, because at a certain point, it's better just to make sure they don't have cancer at the moment. And I'm not as interested in preventing cancer when they're 107 years old, because that doesn't make any sense. And a lot of people, as they get older, the small risks of colonoscopy do go up a little bit, and they don't want to necessarily go through the whole thing with the prep and holding certain medications, and the whole thing becomes a little more inconvenient. But that age is often up there. It's not the 60-year-old, it's not the 70-year-old, it's the 75 to 85-year-old with some other health problems. And those people are probably best served with these non-invasive tests if that's what they want to do. And I've met people who are 80 years old and want to get screened, and they want a colonoscopy because it's the best test. And they have a couple health problems, but they understand that it's a pretty low-risk test in general, and they want to go ahead and do a colonoscopy to prevent getting cancer because their spouse or their friend or whoever had colon cancer when they were 88, and it was still a miserable experience. So they want to prevent that. And that's a valid thing as long as they are in good shape and can undergo colonoscopy and can potentially undergo other interventions if something's found. So the younger people are, I think colonoscopy is better. As they approach an older age where colonoscopy might be more of an inconvenience than a benefit, then we switch to these non-invasive tests. But I don't think we should offer these non-invasive tests to patients who are 45 of average risk without them fully understanding the fact that they may be missing cancers and are most likely missing polyps, which turn into cancer. So hopefully that was helpful, and that's my thoughts on how I test people. And if you'd like to leave me some comments and some questions, I would love to hear from you. If you want to leave me an audio question, there's a link in the show notes below, and you can leave me a quick audio question that I can answer in a future episode, like a Q&A. And if you want to leave me a good colonoscopy story, I love those too. I'm trying to compile an episode on great colonoscopy experiences and bad colonoscopy experiences, so I can kind of like tell people what's going on with colonoscopies from other patients, not just my own feelings on colonoscopy. And if you have a friend or a family member who's not been screened, send them this episode and a roll of toilet paper and tell them to get a colonoscopy. All right, if you have anything else, you can find me on the social medias at RealGIDoc, and I'll see you next time. Thanks for listening.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.